Next is about the appendicitis. Now, before going to the appendicitis, a bit about the anatomy of the appendix. Appendix is considered as a vestigial organ. Vestigial organ in the sense which doesn't have any known functions. But important is it doesn't have any known functions, but real functions are not known. That's the important issue. There may not be any organ which without any function in the body as such. Anyway, that's a different issue. And it's considered as an extra organ and having an independent blood supply of appendicular vessel and having a mesoappendix. And the positions of the appendix could be varying. Majority of the situations it will be retrocecal. It's behind the cecum, as such, that's 64%. And then of course the pelvic position where it is related to the pelvis. Now these positions are important from the clinical point of view. The clinical symptoms can vary in a patient of appendicitis with these positions. Then you have pre-ileal and post-ileal. Pre-ileal is just anterior to the ileum and post-ileal and behind the ileum. Subcecal is just on the sides of the cecum. But majority of the situation it's in the retrocecal position. From the operative point of view also, this knowing about the positions are important. Now, appendix otherwise is a organ without many known functions, but it may become inflamed, and when it is inflamed, it could be resulting in what we call as the appendicitis. Now, causes for the inflammation could be always there is primarily there would be some obstruction. Unless there is an obstruction, it may not get inflamed. That's the basic philosophy. Of course, many times even without known cause of the obstruction, the inflammation could occur. We call it as idiopathic. Causes, of course, normally appendix has some amount of lymphatic tissue. But if that lymphatic tissue becomes proliferated, increased in quantity, it also can result in obstruction. And the triggering factor for the lymphatic tissue to get hyperplasia could be any other infective pathology in the abdomen. So any other infective pathology in the abdomen, or it could be even the infective pathology within the intestines, as occurs in case of the food poisoning and so on. Or another factor which often results in that lymphatic hyperplasia is upper respiratory tract infections. Patients who have upper respiratory tract infections, particularly in children, when they swallow the phlegm which contains the infected product, it also can result in lymphatic hyperplasia in the GIT. And that lymphatic hyperplasia in the GIT, if it involves the appendix or if it reaches to the area of the appendix, it can be a cause for the appendicitis obstructions. Obstructions of this appendix also can occur due to fecolids, hardened stool masses, or worms. At times it could be some foreign body or residual food substances. Another quite significant would be neoplasms. Tumors of the appendix also can occur, which also can trigger the appendicitis. And very important is the tumors of the appendix otherwise do not have any other clinical symptoms. They do not produce any other clinical symptoms until that produces an obstruction and inflammation. And hence every case of appendicitis, particularly in the later half of the life, you have to consider the possibility of a tumor in the conditions as such. As far as the bacterial organisms, species of the bacterial organisms which produce appendicitis are, there are many. Yersinia is more common. Yersinia species are the more common. The viruses like adenovirus, cytomegalovirus also can produce appendicitis. Actinomycosis is another dangerous inflammation or another source which may often result in non-healing ulcers and continuous pus discharge. Like tuberculosis also can result in appendicitis occasionally. Histoplasma species also can produce the appendicitis. But majority of the patients whom we see would be either Yersinia or the other conditions as such. Incidence of the appendicitis is more common in the younger age group. The distribution among the age group would be like in the below 1 year, it's very rare. In pediatric appendicitis is rare, but it produces a unique complications, unique issue, and usually in the very young age between 15 to 25, that's the maximum number of patients who have that appendicitis as such, presents with appendicitis. And of course, the complications of fatal complications, the deaths due to appendicitis, of course, they are very rare, but it increases, the complications increases as the patient goes into the later half of life. In the older age, the complications are more. Appendicitis also has a global factor, or it is a sort of having a epidemiological pattern. In earlier days, in the olden days, incidence of appendicitis was more common in Western countries, particularly Europe and America. It was more common, and in the Eastern countries like in India, it was lesser. But there is a change in the trend now. The present situation is increasing in the Eastern countries, Middle East and South America, Africa, also South Asia. It's increasing in number is increasing in the Eastern countries, where earlier it was lesser, and in the Western countries the number is getting stabilized or gradually getting reduced. Reason, of course, there is no definite known reason. Most possibly it could be related to the lifestyle, because the Eastern countries like India or so on, earlier they had a unique lifestyle significantly different from the Western style, but now because of the globalization effect, the increase in the type of the changes or a type of the food style and lifestyle has changed, and hence there is a tendency for the increase in the appendicitis as such. In India, the exact data is not yet presented known, but there is a increasing trend in India. Number of appendicitis patients are increasing now. Now, basic pathology of appendicitis is the inflammation is triggered, as I told you, due to the obstruction. But initially, the inflammation will be limited to the mucous membrane, the interior as such. And during that period, when the mucous membrane is inflamed, the patient may have a clinical symptom of pain, which is referred to the umbilical area. So, the patient may not have a tenderness at the area of appendix, like in the right lower quadrant, whereas the patient will have the pain in the umbilical area. As long as the inflammation is limited to the mucous membrane alone, it will be a moderate pain in the umbilical area. But gradually, the inflammation may spread towards the periphery, and it may involve the serous layer. When it involves the serous layer, there would be local peritonitis. The outer peritoneal layer will become inflamed, and at that time the patient will have a pain exactly at that point where the peritoneum is inflamed. That's at the appendicular point, or what we call as the Meckel point. So there is always a shift of the pain from the umbilical area to the right iliac area, or the Meckel point, and the time interval between these two, that onset of the pain in the umbilical area and the shift of the pain to the iliac area, is another factor which can even predict the prognosis. Shorter the time taken, the prognosis is poor, or rather it suggests that the inflammation is spreading rapidly. The longer the time taken, it suggests that the condition is relatively chronic and the intensity of obstruction could be lesser. Anyway, this results in the inflammation there. And at the same time, during this inflammation, the whole appendix becomes swollen. There could be many other consequences. Once the inflammation becomes very virulent, even it can result in blockade of the vessels. Blood vessels may get blocked, and the appendix may become necrosed and even perforated. Or that's one of the serious, the most critical issue. When the inflammation is very rapid and very virulent, it can result in a necrosis and gangrenous changes of the appendix. Or if it is comparatively less virulent and the body's defense mechanisms are not really effective to control the inflammation, in that condition it may result in pus formation and an appendicular abscess may result. Or if the body's defense mechanisms of the omentum covering, the omentum would be also called as a policeman of the abdomen. So whenever there is any inflammatory pathology, omentum moves towards the area and tries to control the inflammation, limit the inflammation, and when it occurs, it results in what we call as a appendicular mass, which prevents the inflammation from spreading beyond that area. So the peritonitis or inflammation of the peritoneum would be limited to that area as such. It contains, like, though it may not be cured, or occasionally there could be a spontaneous recovery where the patient may have a complete relief also. So termination of appendicitis could be any of that. Either it could be a gangrenous changes, it may become this abscess, it may be covered up by the omentum, and then gradually it may become chronic inflammation, and in that chronic inflammation the appendix may become fibrous, rigid, and so on, and or there could be rarely a spontaneous termination of the disease also. So the pathology of appendicitis is a very unique, and it may take any different courses. Now these different courses of these appendicitis are reflected in when the description of Shula, Udara, Gulma in Sushruta. Shula is the initial pain stages. It becomes Udara when the omentum is covering that is Gulma, it becomes Gulma. Gulma is Gulmakaraha Swayam Doshaha, where there is only the dosha and the real organ involvement is not important. So that's the Gulma state. And then it can result in Antarvidradi, appendicular abscess can occur, or there could be even the perforation or gangrene and perforation, where it may result in the Udara, Chitrodara complications can occur. So these different courses of the possible complications now, they were considered as different diseases in Sushruta. Now anyway, that's the one point, the other way. Then as far as the symptoms are concerned, the most common, universally seen symptom would be abdominal pain. And that abdominal pain, as I told you, would have a typical character. It gets started in the umbilical area and then tends to move towards the right iliac fossa, gets localized. Majority of the patients, the onset of the pain would be at early morning. Early morning hours, the onset of the pain would be there in the central abdomen around the umbilical area. Gradually it shifts to the iliac area. And when you take the history in a patient of appendicitis, that time taken for the shift of the pain is a very important criteria to decide about the possible course of the treatment later on. Then another common symptom would be nausea and anorexia. Nausea and anorexia is seen in very high number of patients, and whenever the patient vomits out, characteristically the vomiting follows the onset of pain. There would be an acute episode of pain, then the patient vomits out, and vomiting, of course, usually the vomiting produced before the pain suggests of intestinal obstruction. So, or even in case of mesenteric lymphadenitis, which we will discuss later on, the characteristic feature would be the other way, like the pain is pain followed by vomiting is characteristic of an inflammatory pathology in the abdomen, whereas in the other conditions the pain is the pain is prior to the pain is precedes pain is before the vomiting in case of the obstruction conditions. In case of the appendicitis, once the patient vomits out, there may not be a relief of pain, rather it may continue to be there, and characteristically the initial bouts of the vomiting would have more vomiters, but gradually the content of the vomiters may get reduced or absent. That could be retching, there may not be any vomiters as such. So that's true in case of any inflammatory pathology of the abdomen, including appendicitis. Patients also may have either diarrhea or constipation, bowel abnormalities. Diarrhea is more common in ileal positions, pre-ileal or the post-ileal position. Diarrhea is more common as a symptom because of the irritation of the ileum at that level. And in addition to that, some of the patients may have symptoms related to the urinary tract, like this increased frequency of micturition or burning micturition, particularly so in case of the pelvic pathologies, pelvic position. If the appendix is in the pelvic position, irritation of the bladder also can be a clinical symptom as such. Then that's the typical features are, the pain is typically begins at the periumbilical area or epigastric and then migrates to the right lower quadrant, and usually patients lie down. The position would be patients lying down with their hips flexed, and they tend to draw the knees up to reduce the movement. So that's the important issue. In a patient of appendicitis, patients lie down with the hips flexed and knees also bent, so that the psoas muscles are relaxed. Now these kinds of the positions also are important to make out the differential diagnosis at times. Like a patient of pancreatitis would be sitting bending forwards, to reduce the tone of the paraspinal muscles and prevent the movement. So on and so forth. So positioning that the decubitus of the patient also can be one of the additional factors to help in making the diagnosis. And the symptoms are usually seen in within short period. The patient comes to you within 48 hours in majority of the patients. And if the patients have complications like the perforation or so on, it can be prolonged. Then the other typical clinical signs would be a rebound tenderness, that's a pain on percussion or rigidity and guarding. These are signs of the peritonitis, and these signs would occur when the inflammation has reached to the serosal surface, the outer surface, and the peritoneum also is involved. Area of or extent of the area of rebound tenderness or rigidity also is a criteria to suggest about the severity. Larger the area of the abdomen having the rigidity, it suggests that the inflammation is more virulent, or rather there is a complication like a perforation and leakage or so on. So, and in a case of perforation and leakage of the abdomen, the whole peritoneum may become inflamed and the rigidity could be extensive. So, examination of a patient in this also is important. And the tenderness at the right lower quadrant, very specifically at McBurney's point. McBurney's point is a point on the line connecting the anterior superior iliac spine to the umbilicus at the lateral 2/3. But this position is very characteristically seen in patients of retrocecal appendicitis. But it can vary significantly. Some of the patients may have different positions of the appendix, like the location of the appendix also can vary either congenitally or due to certain previous surgical operations, or quite important is in pregnancy. In pregnancy, particularly in the first trimester, there may not be much shift in the position, but later on, as the uterus gets enlarged, the position of the appendix will be pushed up, and hence the patient may even have the pain in the upper quadrant, which can make some confusion in the clinical diagnosis. So that McBurney's point and the right lower quadrant pain, we need to be very careful, though it's a characteristic seen. Of course, as in conditions like situs inversus, where the patients may have a totally mirror image structures, the appendix may be on the left side and there could be pain felt on the left side too, and that's also is quite seen. And particularly in children, infants, young children, the pain even may be presented in the scrotum, because the one in children, there are two factors. Position of the appendix is quite low, and the scrotal tissues still have some, though partially connected to the abdomen, so the patient may have pain and even signs of inflammation in the scrotum could be seen. Now these clinical signs are rebound tenderness is when you have pressed it down, there could be pain, but as you release the pressure, there too the having the pain. Now this occurs due to movement between the inflamed peritoneum, the visceral and the parietal peritoneum. When there is a movement, as you release the pressure, that produces the pain, and that's what we call as the rebound tenderness. Or the similar issues, similar features can be elicited by the other methods, and the other method is when you press on the left side, if the patient feels the pain on the right side, that's what we call as the transmitted tenderness or rousing sign. This is a transmitted tenderness. When you palpate on the left side, patient feels the pain on the right side. This also is produced due to the same phenomena of movement between the two surfaces of the inflamed peritoneum. Or Dunphy's sign is a sharp pain produced felt at the right lower quadrant when the patient coughs or any other rigorous movements. Any other rigorous movements can produce the pain, and that's called as a Dunphy's sign. Or another sign which could be often elicited is the obturator sign. Obturator sign is pain felt in the right lower quadrant, particularly in the McBurney's point, on internal and external rotation of the flexed right hip. You have to make the patient lie down, flex the hip, and then internally and externally rotate the legs. During this, the obturator muscle becomes tonic and relaxed. The contraction of the obturator muscle should occur. If the appendix is close to the obturator muscle, then there could be pain felt due to the same. In all that issue, it is the same thing like movement of the inflamed surface is made out. Or another clinical sign which may be seen is the psoas sign. Psoas sign again is to confirm the relationship between the appendix and the psoas muscle, particularly in the retrocecal appendicitis. This is more commonly elicited when the patient is made to lie down and the hip is extended and the psoas muscle is made to contract. Then you will see the patient will feel the pain at the right iliac area, and that's also is suggestive of a possible appendicitis. Then another often sign is the Meckel sign or heel tap test. Again, it's a similar issue. In the heel tap test, you make the patient lie down, either tap on the heel or ask the patient to stand on the toes and then get down. Now, when there is a sudden pressure on the heel, either by the tapping or the heel coming down during the landing down, it may suggest of peritonitis. Again, the same issue. Now, these signs are characteristically seen in all cases of peritonitis, not only that of appendicitis, but if you have the other positive history of the pain in the abdomen, then it can be considered as appendicitis. Now, these signs, they look like a very sophisticated test slide, but all of them follow the same principle which is mentioned in Sushruta about identification of any shalya, like yasmin todadayo deshe suktata guruta picha ghattate bahusho yatra shuyate rujyate picha atraschaapyam desham abhikshanam parirachate samvakshmanah bahusha tatra shalyam vinirtihita. That patient occupying a decubitus of flexed knee or flexed hip and knee, or even that all that clinical signs like obturator psoas signs and so on, they are of the same principle where you try to make that inflamed appendix move over the other area and elicit the pain, and that's exactly the principle of the clinical examination mentioned in Sushruta. Now, followed by that, the investigations which are quite important. One of the most crucial investigation in case of the appendicitis is the total leukocyte count, and the total leukocyte count helps in confirmation of the diagnosis, as well as it also helps in predicting the possibility, high possibility of the appendicitis. So when the leukocyte count is lower, then the chances of this percentage is based upon the data statistical data. When the leukocyte count is increased, the chances of the appendicitis also are increased. Your possibility of the appendicitis inflammation are increased as such. So that's the universal data, the statistical data of likelihood ratio of 95%, where when the count is more than 17 to 19,000 total leukocyte count, then it's the very high as such. Another very characteristic or very useful investigation is CRP, C-reactive protein. C-reactive protein also can give you some idea about the possible complications occurring. In a moderate, in every case of appendicitis, it may be inflamed and it has a very high index like, and in a case of inflamed appendix, the level could be comparatively around less than 50 or so on. Whereas when it becomes necrotized or gangrenous, the level could be very high, and these are the typical perforated, the level increases. So as the complications increase, the CRP level also would increase. Then the other investigations which are often done is, of course, ultrasonography is not a standard protocol to make the diagnosis of appendicitis, but it helps in ruling out the other possibilities of appendicitis. Normal appendix is not seen in ultrasonography, and many of the inflamed appendix also may be missed with the ultrasonography. So a negative ultrasonography doesn't rule out appendicitis. But when there is a patient of appendicitis, ultrasonography, when you have a confirmed diagnosis of appendicitis, ultrasonography helps in different ways. It can identify the complications easily. The major complications like the appendicular abscess or even the perforation or ischemia, they can be made out. A color Doppler of appendix by ultrasonography can give you a better idea about the vascular status, whether the blood supply is reduced or it's normal. A reduced blood supply is a suggestive of a possible complication of the gangrene later on. A normal appendix, if at all it is seen in ultrasonography, occasionally it's collapsible. Like collapsible in the sense when you press the transducer, the ultrasonography transducer there over the area, it shrinks. But an inflamed appendix would not get shrunken. So a tubular structure may be seen in an inflamed appendix in ultrasonography, a tubular structure which is not collapsible, this are non-compressible. This also could be suggestive of a inflamed appendix. Of course, the other stages, complications like appendicular mass or appendicular abscess, they can be better differentiated by the ultrasonography. Like an abscess where you can make out that collection of the pus easily. With the ultrasonography, chances of missing this would be lesser. A perforated appendix with the leaked air, gas shadow around the area of the appendix, and the layers of the appendix being differentiated, that can be made out with the ultrasonography better. And when the appendix becomes gangrenous, there again that distinct cleavage of the layers of the appendix, the mucosal layer and the serosal layer being separated and presence of the gaseous substances in between, that can be made out with the ultrasonography. So ultrasonography in a case of appendicitis is helpful in identifying the complications of the appendicitis, but it may not be a high sensitive test to confirm the diagnosis of appendicitis. That should be very clear. The appendicitis now can be better confirmed by the either CT scan, particularly triaxial tomography is considered to be very efficient, high sensitivity. Simple CT scan also can make out, particularly if there is any obstructive pathology in the appendix, the cause of obstruction, an inflamed appendix and a ficcolip seen. So that can be made out with the CT scan. That also could be another investigation. Now, some of the variants of the appendicitis would be what we call as the catarrhal or phlemonous appendicitis. Now, these are the factors which trigger the appendicitis. Catarrhal appendicitis is when the mucosal membrane becomes hyperplasic. There is a basic hyperplasia of the mucosal membrane, and hence the appendix becomes thicker, and that can result in obstructive appendicitis. Phlemonous also is a similar issue where there could be some discharges, serous discharges, and fibrosis of the appendix occurs, and that also can result in a gangrenous appendicitis. And ultrasonography can help you to make out these catarrhal or phlemonous. Phlemonous is where there is a fibrinous X-ray around the appendix. Now, catarrhal or phlemonous appendicitis, they are suggestive of a high risk of the gangrenous. Later, it can become even gangrene, and chances of the gangrenous changes are more in phlemonous and catarrhal appendicitis. So, these are all the variants of the appendix presentation in investigations, which can help you to predict the prognosis as well as planned outcome. Now, severity of the appendicitis and confirmation of the diagnosis of appendicitis also, because the symptoms are overlapping, it's done by a typical scoring method. And there are two, of course, there are many scoring methods in vogue, but the more popular methods of scoring are Alvarado score and inflammation rate score, AIR score. Now, Alvarado score is to confirm the diagnosis of appendicitis, where based upon the certain typical clinical symptoms, you get a score like migration of the pain. Migration of the pain in the sense, typical character of the pain starting at the umbilical area and shifting to the iliac area. If that kind of a history is seen, get score 1, anorexia 1, nausea and vomiting 1, lower quadrant tenderness 2, rebound pain or rebound tenderness 1, temperature above 37.3 degrees centigrade, that's a febrile condition 1, leukocytes is more than 10,000, then 2, polymorphonuclear leukocytes which is more than 70% 1, total you will have a total number of score 10. If the score is more than 7, then the patient has a high risk, and usually that condition is suggested for emergency surgery. Moderate risk is 4 to 6 and low risk is less than 4. This is how we can assess the risk as such. Or there is another method of appendicitis inflammatory score or AIR score, where again it's a similar issue, but there is somewhat more detail, like omitting 1, right iliac fossa pain 1, rebound pain 1, it's again you have graded. Moderate is 1, if it is medium 2, if it is strong then 3, Temperature is more than 38.5, then 1. Leukocyte is in between 10 to 14,900, 1. If it is more than 15,000, 2. If it is polymorphonuclear leukocytosis is 70 to 84%, 1. If it is more than 85%, 2. And CRP is also added. CRP 10 to 49 is 1, more than 52. Now the total possible score is 12, and here again, if the total score is more than 7, it's considered as acute or severe conditions which may require emergency surgery, and if the score is 4 to 6, it's considered to be moderate, and less than 4, it's considered as mild. Now, the general principles of the management of appendicitis is the charted guideline. The usual guideline is if the patient is confirmed to be appendicitis by your investigations, a patient presenting with the pain in the right iliac area has to be investigated, and based upon the investigation, if you confirm that it is appendicitis and rule out the other differential diagnosis, I will come to that part of the common conditions which can mimic appendicitis and their differential diagnosis at the end of this. So, after ruling out, the investigations are done. Then with the scores, the same hair score or maybe Eldorado score, you predict the prognosis and you plan the management. And the planning the management would be, either management strategy would be, if it is a lower score and if the patient doesn't have any severe critical illness as such, a non-operative protocol can be tried, a conservative treatment is tried, that's the standard protocol. And if the patient has a high risk as such, suggestive of any of the complications of either perforation or gangrene, patient needs an emergency surgery. Emergency appendectomy is required. Now, from my clinical point of view, I would always treat such acute appendicitis patients with the, and even when the score is less than 10, it's not only 7, even up to AIR score less than 10, we can manage the patient on conservative management. Usually a course of antibiotic of gentamicin and metrogel is what I prefer for 3 days, along with Agni-Tundi, Anandabhairu and Jeerakardirista. And a large number of patients otherwise who have a indication for surgery, the surgery can be avoided. But if the score is more than 10, or if the patient has any of the complications, emergency appendicectomy is needed as such. Now, the standard protocol of the antibiotics. Now, antibiotic which I prefer is the older type of the antibiotics, that's gentamicin and metrogel. Whereas the standard protocol of the antibiotic selection, where identification of the organism and specific selection of the antibiotics is not possible, the general guideline is about the empiric therapy of antibiotics, and empiric therapy which is suggested by the American Gastroenterology Association is the monotherapy with either ertapenem or moxifloxacin, or combination therapy of ceftriaxone, cefuroxime and so on. Indian Council of Medical Research, ICMR, has given a antibiotic policy, has released an antibiotic policy, and in that antibiotic policy, for the gastrointestinal tract infections, you have the choice of the antibiotics, the list of antibiotics like doxycycline, azithromycin, ciprofloxacin and so on. But usually in appendicitis, along with any other antibiotic, a metronidazole is usually prescribed, because in Yersinia groups, metronidazole is quite effective. That's how the conservative management is tried. The other is the surgical option. Surgical treatment again could be either by open surgery or it could be by the laparoscopic surgery. In the open surgery, the approach to the appendix also can vary. By your choice of incision could vary. Lots of or varieties of incisions are tried and becoming popular, were popular at some times, and some of them are popular with some surgeons. Some prefer as such. The common incisions can be even classified as the either the incisions which are horizontal incisions, or it could be vertical incisions. And the horizontal incisions again starting at the right anterior superior leg spine, or it could be gridiron or Rutherford Morrison. These are the very popular incisions. Gridiron incision is rather more popular and more preferable in relatively uncomplicated appendicitis. Most of the times we prefer gridiron incision, either McBurney's modified incision is the more is preferred. The vertical incisions are preferred when there is a definite evidence of a perforation and leakage, because you will have a more scope for exploration, and if there is a need, drainage as such. So, and lavage of the abdomen can be better with the vertical incisions. Horizontal incisions also are often preferred by certain surgeons, but not very popular as such. The type of the incisions or the locations of the incision, common incision is Meckel, which is oblique, where you virtually you do not cut the muscles. In the modified Meckel or gridiron incision, you will not cut the muscles, just split the muscles, which will reduce the complications to a great extent. So that's how open surgery is preferred. As far as the laparoscopic surgery is concerned, laparoscopic surgery has become popular these days, but there are some claimed advantages of laparoscopic surgery also, but what I have found is the advantages are not that significant. In appendicitis, a open simple this appendectomy with open surgery is having more advantages than the laparoscopic. Laparoscopic surgery has, though it's claimed that the possible complications are lesser, but if the appendicitis is complicated, if there is a mass formation or if there is an abscess formation, that cannot be effectively handled by the laparoscopic approach as in case of the open approach. Anyway, that's the issue of controversy, difference of opinion. Now a bit about the historical facts of appendicitis. The first recorded anatomical drawing of appendix was done by Da Vinci in 1508. So the whole knowledge about the appendix is just around 700 years old, like something around 6 to 700 years old. The description of the appendix in writing 1522. But the real major important development, now these are all the typical historical facts, like an inadvertent appendicectomy was done during the operation of hernia in 1731. So first of the appendicectomy was done in 1731 as such. Then the reports of the appendicectomy during operation of groin hernia were done in 1735. Then the abscess drainage was previously done as such. Then the appendicectomy with the typical abdominal incision was done. A standard was done in 1880 with the patient survived. So the whole duration of, or the whole historical timeline of a classical planned appendicectomy is around maybe 400 years, 300 to 400 years old. But during that period, there were a lot of developments, newer developments, and approaches were changed, and the most popular gridiron incision was planned published by Meckel in 1894. And in 2000, the first laparoscopic appendicectomy was done in 1980. And from 1980 onwards, laparoscopic appendicectomy has become more popular. Then of course there are some newer development which are not very popular, like these appendicectomy through transvaginal route, or appendicectomy through natural orifice by putting a gastroscope and then through the gastroscope pulling out the appendix. These are very rarely done surgeries, and there are some claims like these are advantageous. Of course, it's still an issue for theory for us. We have not done that, or we have not seen that. But these kinds of developments also are going on, and maybe in future you may have different techniques of dealing with appendicitis. Now that's about the basic issues of acute appendicitis. Now some more variables and the complications of appendicitis. Appendicular mass is not really a complication, but it's a natural sequelae of appendicitis. Appendicitis, usually the momentum would be covering the area, and hence the mass is formed. Once the appendicular mass is formed, the patient is comparatively safer. The chances of a widespread peritonitis would be lesser. But time taken for mass also can vary according to the patient's general condition. A healthy patient, otherwise, usually a mass is formed within 48 hours of onset of the appendicitis. But in young children, or in very old patients, or patients who have some other systemic pathology like diabetes and so on, the time taken for the mass formation can be longer, and that longer time taken for the mass formation would be is also suggestive of a possible high risk conditions as such. And the clinical signs of the mass formed would be after the acute episode of appendicitis, patient may have a palpable mass in the right iliac area which is soft and is resonant on percussion. That's all the important thing. The symptom resonance on percussion is an important issue. Now, whenever a mass is formed in a case of appendicitis followed by the inflammation, always there would be a confusion between an appendicular abscess and appendicular mass. Appendicular abscess is a sign of worsening and mass is a sign of improvement. So, to differentiate these is quite important, and the clinical differentiation is on percussion. In a case of mass, it will be resonant, whereas abscess will be dull on percussion. Ultrasonography can make out that difference easily. In ultrasonography, appendicular mass will show the soft tissues around the appendix but not much of a fluid. Clinical symptoms will go milder in case of appendicular mass formation. Whereas in an appendicular abscess formation, which is a worsening condition, the patient again would develop a mass, but clinical symptoms of fever with the chills would be more prominent. Rather, initially there may not be chills in the patient, but once the abscess is formed, the patient may even have the chills. Pain becomes more constant and exactly located at the area. Nature of the pain also may change into aching type of the pain. Anorexia and persistent glucositosis are the other signs. Ultrasonography can make out the diagnosis of appendicular abscess easily, and in case of appendicular abscess, surgery is absolutely necessary, and in that surgery, it's whether you do the appendicectomy at the same level or drain the abscess and then plan for a second stage appendicectomy. That depends upon the other variable conditions like general condition of the patient and the status as such. As far as the otherwise healthy patients, it's better to have appendicectomy and the drainage of the abscess simultaneously. But if the condition doesn't permit, then the drainage has to be done initially, and once the patient has recovered, then the appendicectomy could be planned. And the route for a drainage could be either perrectal or even pervaginal routes also are often done than perabdominal. Perabdominal is the usual incision as you make for the appendicitis and then keep a drainage over there. Or perabdominal or pervaginal routes also are often done with relative safety and relative lesser complications. Then another variant would be the chronic appendicitis. Chronic appendicitis is a consequence of the acute appendicitis. Usually, patient may have a history of acute appendicitis followed by a recovery, and then the patient may continue to have vague pain in the abdomen, and the localization signs may not be very accurate, like it may not be felt exactly at the area, and the patient may continue to have anorexia, malaise, or diarrhea, or irregular bowel habits could be there. Patients presenting with these symptoms, it's important to rule out either urinary infections or nephritis or Crohn's disease, ulcerative colitis, ovarian cysts, or pericardial disorders, or irritable bowel syndrome. These are all the conditions which may mimic the clinical presentation of a chronic appendicitis, and they need to be ruled out. And only after confirming that, you may make the diagnosis of chronic appendicitis. Chronic appendicitis also is better made out with the ultrasonography, where thickened and fibrous appendix can be seen with the ultrasonography as such. And of course, once you have made out the diagnosis, the better treatment is surgery. Though not it is an emergency, planned appendicectomy is the treatment. One more condition which mimics the conditions of appendicitis, which is one of the important differential diagnoses of the appendicitis, is mesenteric lymphadenitis. Mesenteric lymphadenitis is a non-specific, self-limiting inflammation of the mesenteric lymph nodes and is presented due to the inflammation of the appendix. And for the clinical diagnosis criteria, the size of at least 3 lymph nodes should be seen and should be more than 5 mm in diameter when they are noted in the ultrasonography. When during the ultrasonography, if lymph nodes which are swollen and at least 3 of them are seen and their diameter is more than 5 mm, then the mesenteric lymphadenitis diagnosis is done. The organisms which produce this mesenteric lymphadenitis could be varying. Either it could be Escherichia, Streptococcus. Yersinia is more common. Majority of the patients are of Yersinia species. Tuberculosis, Giardia viruses also can produce mesenteric lymphadenitis, or patients of HIV also can have mesenteric lymphadenitis. And majority of the patients is a self-limiting disorder which doesn't require any energetic treatment. Clinical symptoms will be classically similar to that of appendicitis, like acute abdominal pain at the right lower quadrant, or may not be very accurately defined. That location may not be accurately defined. It may be even vague or generalized as such. Exactly at McBurney's point, it may not be restricted. Fever, diarrhea, anorexia, and upper respiratory tract infections. More commonly, patient may have a upper respiratory tract infection prior to this abdominal pain, or maybe correspondingly at the same time it may have nausea and vomiting. Now, with the vomiting, which is very characteristically, the vomiting is before the abdominal pain compared to the appendicitis. So that makes the difference. Otherwise, the clinical history will be similar, but vomiting will be before the pain occurs. Then history of ingestion or of raw pork also often there could be, particularly raw pork is considered to be one of the triggering factors in case of mesenteric lymphadenitis. And the patients of mesenteric lymphadenitis, there is no specific treatment. There is only the supportive care. Like when the patient has pain, you may give analgesics, and if the patient has more vomiting, hydration may be given, and there is no need of any specific treatment. Usually the symptoms subside in a week or so. Of course, when I treat, I prefer the same Adnitundi Ananda Bhairavi and the Jirakatirista as the options of the treatment, and that helps in recovery of these patients as such. That's one of the condition. Then another of the condition which can mimic appendicitis is and which can produce a confusion clinically is Meckel's diverticulitis. Meckel's diverticulum is a congenital variation where the patient may have a diverticulum, true diverticulum with all the 4 layers over there at around 2 feet proximal to the ileocecal junction, and it's often seen in 2% of the people, and the diameter is around 2 centimeter. A Meckel's diverticulum can present in any form. Either it could be a simple diverticulum or a diverticulum with a band which is adherent over the umbilicus area. Size of the band also can vary, and this diverticulum can produce various complications. One of the complications is the diverticulum may become inflamed due to the stasis, and that produces what you call as diverticulitis. The other complications could be, there could be ulcerations, perforation also can occur, hemorrhage could occur, it can result in obstruction, and the perforation could occur. And from the appendicitis differential diagnosis point of view, diverticulitis is the issue. Diverticulitis presents with the exactly similar clinical symptoms as that of the appendicitis, but again, the location of the pain, localization may not be exactly at the McBurney's point, it may vary, and most of the times the diagnosis is done by the surgery only, but investigations like ultrasonography, CT scans can help you to make the diagnosis. Clinical features are almost similar to that of the appendicitis, but tenderness may be felt more medially, more than the typical location of the McBurney's point. When ultrasonography can identify these inflamed diverticulum, even CT is better to rule out or identify the diverticulum. Treatment is essentially surgical treatment, and the treatment is usually diverticulectomy. With this, we will conclude today, and next we will continue with the colitis-like conditions. If there are any questions, we will try to answer the questions. There is a question, since there are various organisms involved in mesenteric lymphadenitis. So that's the chance. You may have to go for any of the choice of the investigation or these antibiotics. Majority of the patients of mesenteric lymphadenitis do not require antibiotics. That's the point. Mesenteric lymphadenitis do not require antibiotics unless the patient may have a systemic complication. And whenever you have to go for the empiric therapy, the same antibiotics which I have suggested earlier, that the universal standard is meperidine, but ICMR recommendations, you have a list of those antibiotics, ceftriaxone or so on. And the older generation, like me, I would prefer gentamicin if necessary. That's about the antibiotic choice, right? Any other questions? Right. Thank you.